Hello, I'm Dr. Naveen Pamaraju, Associate Professor in the Department of Leukemia at MD Anderson. Today we'll be discussing the clinical presentation of blastic plasmacytoid dendritic cell neoplasm, or BPDCN. Blastic plasmacytoid dendritic cell neoplasm, or BPDCN, presents with a protean number of manifestations in the leukemia clinic. Unlike most of our other diseases, BPDCN usually presents with three major compartments, either involved simultaneously or one at a time. These three major compartments are number one, the most common, the skin or cutaneous involvement, number two, the bone marrow, and number three, the lymph nodes. In addition to that, there are common secondary sites or extramedullary presentations even outside of the skin and lymph nodes. These do include commonly the central nervous system as manifest by CSF positivity, and even still other visceral sites that do commonly occur in BPDCN. Now, the question of how frequent is the CNS involvement is one of active research. There is a study by our colleagues, Martin, which reveals that there is a high rate of occult or hidden CNS involvement in patients with BPDCN. In a recent study of 13 consecutive patients in which they prospectively screened with lumbar punctures, none of these patients had CNS symptoms at baseline, but remarkably, 6 out of 10 or 60% actually had a positive lumbar puncture result with active disease, and 3 out of 3 or 100% of patients had this at progression or relapse, even in the absence of symptoms. They further went to do a retrospective cohort with 23 patients, and those who received intrathecal prophylactic chemotherapy with intensive chemo regimens were found to fare better, with a better overall survival and a better CNS recurrence-free survival. Now, these three major compartments in BPDCN that we measured are very important because in this historically rare cancer, we had no standard response measurement criteria or tools available, and therefore we put forward the following criteria into the clinical trial for tagraxofusp, the phase 1/2 trial that ultimately led to FDA approval. Now, the sites of disease, as we mentioned, are three: skin, bone marrow, and lymph nodes. And then the assessment tool is as shown on this slide. Let's go through each one. In the skin, we borrowed from the existing literature in the cutaneous T-cell Sézary syndrome mycosis fungoides literature to use the MSWAT, the modified surface assessment tool. For the bone marrow, we used the standard Cheson AML criteria by bone marrow biopsy, and for the lymph nodes, standard Cheson non-Hodgkin's lymphoma criteria for imaging, either using the CT or the PET-CT scan. Now, the footnote at the bottom of the table is important as it indicates that there was an entity called CRC, clinical complete remission, which, because the clinical trial called for biopsies, including blind skin biopsies, which could still show no gross evidence of observable disease, but still microscopic disease on a biopsy, and this was designated as the CRC. Clinical demographics of BPDCN are important. The median age in most adult series is usually older. This is late 60s to early 70s. There is a male predominance, interestingly as high as 5-1 in some series, and even though the patients are known to have a population of so-called pediatric or AYA, adolescent young adult patients, this is less commonly seen than the more common presentation of the older adult with BPDCN. So how do we recognize, identify, and manage patients with BPDCN in the real world in the clinic? Well, the first challenge is the accurate diagnosis. And what we and others have found is that the assistance of flow cytometry and IHC, or immunohistochemistry, by our pathology colleagues has been instrumental, has been key in the diagnosis of BPDCN. Again, let's go through this in detail. At the level of pathology, either the flow cytometry or the immunohistochemistry can reveal the triad of CD123, CD4, and CD56, and a mnemonic to help you remember that is to think CD1, 2, 3, 4, 5, 6. Now, we are frequently asked if there are other markers that the pathologist and clinician can use to help rule out or solidify or specify the diagnosis of BPDCN, and there are. 3 of them are listed here. The TCL1 marker, CD303, and TCF4 have various literature supporting these in the pathology and clinical guidelines. and they can assist in ruling out mimicking or competing diagnoses, such as AML with leukemia cutis or lymphoma states. In further thinking about how to recognize and diagnose our patients, we often turn to cytogenetics and FISH as we do in our other leukemia and lymphoma diagnoses. Now, in terms of cytogenetics, unfortunately, there's no true pathognomonic, recurring, dominant driver that 100% of the time occurs in BPDCN. But in terms of FISH, there are some emerging data sets that one common theme may be the MYC rearrangement or 8q24. This does not occur in the majority of patients, but the patients that it does occur in, the conventional cytogenetics may not pick it up, and FISH may be needed to be involved. And so further research will be needed to delineate from a cytogenetic and FISH standpoint. Interestingly, we actually know a bit more about the molecular components of BPDCN than the cytogenetic. In terms of molecular, the common pearls are that most of the mutations center around the known mutations we have in MDS, CMML, and AML, and by far the most common mutation or variant appears to be TET2 for BPDCN. After TET2, there is several other common mutations that include ASXL1, RAS, TP53, among others. Interestingly and very importantly for the clinician, in our experience with BPDCN, it appears that a small but significant subgroup of patients, maybe up to 1 out of 5 patients with BPDCN, may actually have a prior concomitant or just after diagnosis of an MDS, CMML, and so this is very important as both of these express very similar molecular mutations. So in summary, I want to go over the common 3 sites when making a diagnosis in the clinic of BPDCN. And those involve, number 1, the skin, most common, followed by the bone marrow at number 2, and number 3 is the lymph nodes. I also want to emphasize that there are other so-called secondary sites that you can see in the patient with BPDCN, and that includes the central nervous system, as well as other extramedullary sites as we discussed earlier. In terms of diagnosis, this complex disease has some helpful markers, which include CD123, 4, and 56, and you can remember it by the mnemonic, think 1, 2, 3, 4, 5, 6, and other markers as we listed to help in the specificity. And finally, although there are no recurrent dominant cytogenetic lesions, there are some common molecular mutations, most notably the TET2 mutation. Thank you very much for your time and attention, and good day.